It's actually a very interesting opportunity for me to be here because I am going to represent my dermatology department in England, but I'm Italian. And I started my career in nursing in Italy, and I moved to the UK, I think 12 years ago. So yeah, it's quite nice to be back on a professional capacity. So I have no conflict of interest. So this is a photo of the entrance of Kingston Hospital. Not Kingston in Jamaica, although I wish the weather was the same, but it's Kingston it's a lovely town in southwest of London. And the peculiarity is that patients with moderate to severe psoriasis, especially those patients on biologic treatment, they're seen independently and exclusively by specialist nurses. There's very, very little medical input. And you know, if I had to go back to Italy maybe 12 years ago and I went to the hospital in Italy or even in other country as well and say, listen, all the patients with moderate to severe psoriasis are seen just by nurses, not by doctor, you would have some dubious reaction. People would be a bit diffident about that. Right. But of course, I mean, just to talk briefly about the history, in the UK, legislation has allowed nurses to be quite independent and gain advanced practice already in the early years of 1980s, 2000, and since 2006, nurses who do a specific training are able to prescribe all drugs within their scope of practice. That's what allows us to be able to deliver this service. So how does it work? So imagine you're a patient with psoriasis, moderate to severe. So your GP referred you to the hospital, and your first point of contact is going to be a physician, so a doctor. So they will assess you, and they will establish on whether you need treatment, could be topical, phototherapy, or a systemic drug. And then if you fail 2 systemic drugs, so methotrexate or cyclosporine, for example, they would refer you to the nurse-led clinic. But equally, they could refer patients straight away to us, and we can initiate any systemic treatment. Once we see the patient, then we will establish the appropriate treatment, and we'll keep on monitoring them, and they won't be seen again by a doctor. Now, we haven't made our doctors redundant, of course. Our doctors are there, and our lead consultant will support us whenever we have a very difficult scenario, a very unusual patient, so they are there to support us. But for the 95% of the cases, we see our patients independently. So what we do when we see a patient for the first time, we do the obvious, so a medical assessment, history taking, so we focus first on the skin, we assess the severity, we do our PASI scoring, the drug history. But then we are nurses, right? So we have the gift of seeing patient holistically, and that kind of links to the previous presentation of our colleague from Portland. We perform a holistic assessment. So we do ask our patients lots of questions about diet, exercise, sleeping pattern. We look at diabetes, hypercholesterolemia, hypertension, cardiovascular. We look at their joints. And then we have the ability to we are linked to local services who will address these issues. For instance, we refer a patient to a smoking cessation service or a alcohol cessation, and we have health and well-being services, which in the UK, at least in our area, are free, or even weight loss services. And then educating. Education is really, really important because nowadays, I still have young patients thinking that they are going to infect other people with their psoriasis. So it's very important for them to understand this is not just a disease of the skin, it's a disease of your immune system, and therefore is associated with the whole plethora of comorbidities. And I think the key word is activate. Activate your patients to seek remedy and seek further support, because it's not just about the skin. And once we see an incredible shift, because once a patient understands, we even describe the mechanism of action of the drugs we prescribe. Of course, we're not very technical, but at least they understand that if they take that pill, if they have that injection, it won't magically heal their skin. It's just about the immune system. And we notice that patients start adhering to the treatment. They take their tablets, they take the medication. They understand why they take it. Knowledge is power. After we do this assessment, we then establish the most appropriate treatment. And we do that by obviously looking at guidelines, but to be honest with you, nowadays there's a new biologic every 3-6 months, so we do a lot of literature review. We are actively involved in research, so we look at comparing data between different biologics, safety, efficacy, and we tailor the treatment to our patients. We look at their comorbidities, age, if it's the first biologic, the second, if they failed previous biologics, and of course, if they're needle phobic, we consider all these things and we tailor the treatment. Then, of course, we initiate the treatment, we initiate our monitoring, blood test, chest x-ray and all these things, and then we keep on monitoring our patient, and the patient stays with us unless there's an unusual scenario and one of our consultants will come and support us. So since the management of patients with on biologics was taken over by the CNSs, the clinical nurse specialists, we have noticed an increased number of patients on biologics because it's much more accessible. So can everybody do that? Myself and my colleague who are leading this clinic, that currently 4 clinical nurse specialists working in this psoriasis clinic, we look at the profile. So in order to be able and to be competent in making decisions and monitoring your patients, I think you need definitely a postgraduate education level, so like a master degree, being able to constant attend local, national and international updates, being a non-medical prescriber, being actively involved in research, train other peers. We often train our doctors because they're less experienced than us on biologics, and we have to be able to influence the local policies and the governance. Research is a vital part of our clinic. So myself and my colleague Saskia, we are principal investigators for observational studies, part of a national consortium, and I don't think there are many nurses being PIs for these type of studies, but it's great that our National Institute for Health and Research is promoting that, and hopefully soon we have more and more nurses becoming PIs. What we created is a sort of symbiotic relationship between clinical practice and research. In fact, we have our research associates and research nurses just working on a room next door to ours. So we see our patients, we have 30 minutes, we do our consultation, and after that they go and see the research nurse. And what they do, they collect further data and then we cross-check. Sometimes things can slip through the net. For instance, I had a patient who had elevated liver function test, and of course the obvious question is, how much do you drink? And he told me, oh, just a glass of wine every 2 nights with a meal. Fine. So they went to see the research nurse next door, and they said, oh, you know what? I told Alberto I drink 1 glass of wine every 2 nights, but actually it's a bottle of wine every night. So obviously we cross-communicated, and we referred the patient to alcohol cessation clinic. So that to tell you how important it is to be involved and using research, not doing research, using research. So within 3 years that we've been principal investigators, we have recruited 191 patients to 5 studies, both commercially and non-commercially. So we're delivering something which is quite innovative, quite new, and of course a lot of people may raise their eyebrows and thinking, oh, seen just by nurses, would that work? And of course it's very important to audit our work, because ultimately we don't do it for the glory, we do it for our patients. So in 2015, we invited some biologic patients and their family to take part to a focus group, because at that time one of our doctors wanted to take part actively be part of the biologics clinic. But these patients and their family, what really liked was the fact that they are seen holistically. Unfortunately, our doctors, they only have 5-10 minutes for their consultation, so that they can't perform an holistic assessment. They're brilliant, don't get me wrong, but they don't have the time. We are very easy to contact. The clinical nurse specialist is very easy to approach. I give my business card, they can email me, they can call me. It's very easy to get in touch with us. And they always see the same person, which is great, because sometimes it can be demoralizing. Every time they go back to the hospital, they see a different person. And of course, they like the empathy for the psychological impact of the disease. So 2 years ago, and now we're going to do it every 2 years, we submitted a feedback questionnaire, which is anonymous. So we submitted a questionnaire, and 50 of our biologics patients responded, so we don't know who they are because, of course, it's anonymous. And just quickly go through the results. So 76% stated that it's very easy to contact the specialist nurse, 20% easy, which is great. The majority of them think they got enough time, so it means they're listened. 100%, remember when I mentioned about education, 100% of our patients thinks that the clinical nurse specialists explain things clearly. And how did they rate the survey? So 90% excellent and 10% very good. No one said it's average or they don't like it. And I think this quote from one of the patients who participated to the feedback questionnaire, I think says it all, it summarizes. So having had care in a range of places and seen many specialists, the specialist dermatology nurse is the only person who has fully understood the condition, the impact it has, and helped me devise a plan to manage it rather than just giving a prescription. Thank you very much. Any question?